Hello, my name is Jill Osborne. I'm the founder of the Interstitial Cystitis Network. I've been a support group leader for 31 years, built the first website on IC in 1994, and it's been rated the top website in 2 peer-reviewed studies. I've allocated funding for IC research as a CDMRP research panel. I currently serve on the AU8 Guidelines Committee for Male Pelvic Pain. I've been a guest lecturer. I'm a co-author of the book IC 101, It's Not Just a Bladder Disease. But your patients might know me because I run live support group meetings almost every Sunday on YouTube and Facebook. Now, in this seminar, we're going to talk about phenotyping in the diagnosis and treatment of IC. Our objectives are to review the history of phenotyping proposals and their recommended treatments. We're going to review the practical application of phenotyping in your clinic using 6 case studies. And we're going to explore the value of phenotyping in patient education because it really works. But we're going to start with 6 patients, each diagnosed with IC. We have a 74-year-old female. She has severe pelvic pain, frequency, urgency in the past 20 years. Her symptoms have worsened over time. She has a poor quality of life and functionality, and she has severe depression. Cystoscopy finds severe Hunner's lesions. Fulguration and steroid injection has happened multiple times, but the lesions continue to recur. She was on Elmeron for 20 plus years with little effect. She's currently struggling with pigmentary maculopathy. She's used antidepressants for a long time, and she is very diet sensitive. Patient number 2 is a 38-year-old male. He's a U.S. Army paratrooper. He has moderate pelvic pain exacerbated by sitting. He has pain at the tip of his penis. He must strain to urinate, and he self-catheterizes occasionally. His prostate is normal. Standard IC therapies are ineffective, not diet sensitive. Now we have a 30-year-old female. Her frequency urgency began in her early teens. She has persistent pelvic pain, especially with menstruation. She has early onset endometriosis with multiple excision surgeries. She has some IBS, migraines, pelvic floor dysfunction. She works as an attorney, and she's very diet sensitive. Our 4th patient is a 20-year-old male. He had sudden onset frequency urgency pain at the age of 18. He currently has severe pain on bladder fill, prostate normal, dropped out of college. He's bedbound, very diet sensitive. Our 5th is a 56-year-old female. Her frequency urgency began at 54. She has moderate nocturia. Her pain is described at the urethra and the vaginal introitus. She has pain with intercourse. She has pain on bladder fill. And she can no longer enjoy a cup of coffee. She is diet sensitive. And last but not least, we have a 13-year-old female. Sudden onset frequency urgency. Can't sit through class without asking to use the restroom. Urine culture is negative. Urethral dilation is ineffective. Very diet sensitive. Each of these patients has had negative urine cultures. Each was provided antibiotics with no effect. Each was eventually diagnosed with IC or bladder pain syndrome. They were specifically told they had an incurable bladder disease, and they each experienced a poor response to conventional IC treatments because they continue to suffer from flares. So what do we know in 2024? We know that the IC patient is remarkably diverse, including age of onset, culture, profession, and history. That a one-treatment-fits-all approach such as Elmeron does not work for the majority of patients. We know that the U.S. National Institutes of Health has invested more than $100 million in IC treatment research, with only one study found to be significantly successful: pelvic floor physical therapy. So I ask you, if physical therapy is successful when other bladder therapies are not, is this really a bladder disease? So let's take a look at a quick history and how perceptions of IC have changed over time. So in our earliest history, in 1836, Parrish described IC symptoms as tic douloureux of the bladder. He suspected that it was a neuralgia of some type. In the 1850s, Physick and Burns described patients with mysterious bladder pain in which no stones were found. Also in the 1850s, Gross described inflammation of the bladder wall, and he wrote, quote, "The chronic form of the malady entails a vast amount of suffering, which, continuing for months and perhaps years, finally saps the foundation of life." In 1915, Dr. Guy Hunter identified ulcers on the bladder wall of some but not all patients. These are now known as Hunter's lesions or Hunter's ulcers. And in the 1940s, Dr. Hand described small, discrete submucosal hemorrhages and dot-like bleeding points, which we now know as glomerations, that he believed represented the true nature of IC. But these are no longer considered a significant finding in the 2022 AUA guidelines, as they are not unique to IC-BPS. Now, in 1987, the US NIDDK created the first guidelines for IC research in which a diagnosis was to be confirmed by the presence of Hunter's lesions or glomerations. And these guidelines were quickly adapted in a clinical setting. However, later research found that 60% of patients did not have Hunter's lesions or glomerations. So again, if this is the case, is IC a bladder disease? So clearly, at that point in time, they believed that there were two groups of patients. There was a group of patients with Hunter's lesions demonstrated by gross inflammation on biopsy, and there were a group of patients without Hunter's lesions that rarely had inflammation on biopsy. Glomerations and petechial hemorrhages are not unique to IC and often the result of hydrodistension, especially the old high-pressure, long-duration procedures. Now, in 2001, Dr. Jerome Weiss was one of the first urologists to expand his practice to include the assessment and treatment of pelvic floor muscles. His first study showed that physical therapy was remarkably successful. 45 women, 7 men with IC or urgency frequency syndrome had manual physical therapy for 8 to 12 weeks. 83% had moderate or marked improvement. Resting pelvic floor tension decreased from 9.73 to 3.61. And yet, this was essentially ignored by mainstream urologists for many years. In 2003 through 2007, Dr. Rhonda Cotterinos and Mary Pat Fitzgerald published one of the first protocols to rehabilitate hypertonic pelvic floor muscles found in bladder and pelvic pain patients, including associated trigger points and connective tissue abnormalities. Dr. Ken Peters at Corewell Health demonstrated a clear association between IC and pelvic floor dysfunction in a study of 70 women. Now, in 2008, the International Society for the Study of Bladder Pain Syndrome, now known as the Essex Society, released their consensus statement on BPS-IC, which they did define as a bladder disease. In their system, a diagnosis requires hydrodistension and biopsy of the bladder wall, and patients are ranked based upon the severity of their bladder wall combined with biopsy results. And they identified 12 distinct variants. However, their system is not viable through most of the world because hydrodistensions may not be available or may be cost prohibitive. Here in the United States, hydrodistension is only performed if the diagnosis is in doubt. However, flexible cystoscopy may be an option. Now, in 2019, the Japanese and the East Asian guidelines for IC were released, and they suggested the term hypersensitive bladder syndrome. They suggested that bladder hypersensitivity is associated with urinary frequency and pain. And they were the first to discuss in depth the concept of neurosensitivity in the IC patient population. And in 2009, we had a real significant breakthrough. A multi-center NIH research network study found that pelvic floor physical therapy reduced IC symptoms significantly, 57% versus 21% in the placebo group. This was indeed a critical turning point because this was a validated study proving that physical therapy was in fact more successful than oral meds. So if IC was a bladder disease, why would physical therapy help? Now, the other big thing that happened in 2009 was the proposal of the U-point system. Dr. Dan Shoskis and Curtis Nickel introduced the very first phenotyping system for chronic prostatitis, chronic pelvic pain syndrome. They encouraged the development of a customized treatment plan based upon 6 key domains: urinary symptoms, psychosocial functioning, organ-specific finding, i.e. Hunter's lesions or not, the presence of infection, if any, neurological health, and muscle tenderness. They then asked doctors to create an individualized treatment plan based upon each patient's domain scores. UPoint was eventually adapted into a system called Input that is currently recommended for use in the Canadian Urology Association guidelines for IC-BPS. So what did the patients think of all this? Well, patients were ecstatic to see their whole body assessed rather than just the bladder, because this was the first time someone addressed widespread sensitivity, which we had been discussing for years. I mean, why do so many patients have a very sensitive skin or a wicked sense of smell, which we now recognize is a sign of central sensitization and widespread pain? And so UPoint was the first system that truly emphasized the development of an individualized treatment plan. Now, in 2011, the American Urology Association guidelines were first released, reflecting some but not all of these changes. Though they referred to IC as an incurable bladder disease, they added pelvic floor muscle assessment and referral to physical therapy as a treatment option. This expanded the care from traditional therapies to include manual therapies. But please note that in their 2022 update, they said that no bladder disease is found in the great majority of cases. They focus instead on neuromuscular origins for the majority of IC patients. Now, that said, the guidelines are a fantastic document, but I believe that the majority of practicing urologists in the United States have not reviewed them, much less looked at the updates released in 2014, 2015, and 2022. We still have doctors treating IC out of old textbooks. So let's go to 2015. Dr. Christopher Payne, professor emeritus from Stanford University, proposed 5 phenotypes for IC. His rationale: he said a diagnosis of IC doesn't give the patient or provider a clear treatment plan or pathway. As a model, he asks us to look at the far more in-depth diagnoses provided in cancer care, arguing that they have a clearly identifiable treatment plan. And with phenotyping, IC patients can receive a more accurate diagnosis and more effective treatment plan. He proposes 5 core phenotypes, but also suggests that there are probably more. In his system, his subtype 1 is Hunner's lesions. These are patients who have profound inflammation on biopsy. They have extreme symptoms, extreme diet sensitivity. Multiple studies have now found virus in the urine of these patients, including the polyoma BK and the Epstein-Barr virus. However, a case study also found posterior fornix syndrome related to lesion development. So what's our treatment priority for Hunner's lesion patients? Well, lesion-specific therapies, fulguration, laser therapy, steroid injection, maybe hyperbaric oxygen therapy. These patients can suffer for years if they are not provided lesion-specific therapy. Antivirals are currently being studied for patients who do present with active and viral infections. And of course, for this group, they need consistent pain care, monitoring, and diet modification is especially critical. Now, in the pain system, our second phenotype or subtype is bladder wall driven. And in this, there are 3 or more variants. The first one is chemical injury. So these are the patients whose symptoms are the result of chemotherapy, maybe ketamine use, or maybe a terrible diet, drinking way too much soda or coffee. We're also going to look for genitourinary syndrome of menopause and signs of estrogen atrophy. And we're going to look for chronic infection, bacteria, but also fungal infection, viral infection, maybe Lyme disease, or maybe even some black mold. Our therapeutic priority in this group is to remove the irritants, address skin health and GSM with topical estrogen. We're going to use oral meds to help manage symptoms and reduce mast cell activity. However, you want to be cautious of pentosan and Elmeron because of its associated risk of pigmentary maculopathy and inflammatory bowel disease. We're going to use some bladder installations, like a typical rescue installation of heparin lidocaine. And the AUA does encourage the use of over-the-counter supplements because they have less risk of adverse event. So they suggest their use before the use of more traditional medications. Now, in the pain system, our third subtype is pelvic floor driven. So in these patients, you're going to find a history of previous pelvic trauma, car accident, falls. They may have a history of childhood athletics or extreme athletics or dance. They may have sustained injuries during childbirth. They may have been a victim of sexual abuse. Often their symptoms can begin at a young age. And the important thing to remember is that long-term tension can result in pelvic ischemia. So our therapeutic priority for this group is to obtain a comprehensive pelvic floor assessment by a properly trained PT. We want to restore normal muscle tone. It's important to note that a healthy muscle feels like a raw chicken breast, a tight muscle feels like a cooked chicken breast, and a badly damaged muscle will feel like beef jerky. We want to address trigger points with manual therapy and trigger point injections. And if muscles are returning to chronic tension despite physical therapy, we want to assess and address underlying skeletal problems, such as a problem with the SI joint, tailbone, hips, knees, or feet. And patients should be taught to recognize tension early and treat it with stretching and internal massage. Now, our fourth subtype in the pain system is pudendal neuralgia. This is driven by nerve injury and dysfunction. So these patients have positional symptoms. They may feel fine when they stand, but when they sit down, it hurts. When they bend over, it hurts. They may be experiencing pins and needles sensation, areas of numbness, some PGAD, or some fasciculations. This occurs as a result of tight muscles compressing nerves, such as sciatica. It often is caused by bike riding, horseback riding, motorcycle riding, or for sitting for long periods of time. Our therapeutic priority for this group is to identify the compression location, reduce the contracture, and reduce normal tone with physical therapy. We want to calm nerves topically and internally with topical anesthetics, nerve blocks, and nerve calming meds such as PEA or Neurontin. Most importantly, we want to avoid those things which will irritate that nerve, such as bike riding, sitting for long periods of time, and other triggers. And our last subtype is central sensitization widespread pain. These are the patients who have IBS, vulvodynia, TMJ, fibro, migraines, etc., etc. They might have two or more of those pain conditions. But they will also have extreme sensory sensitivity. They may have very sensitive skin, a wicked sense of smell or taste, or a sensitivity to sounds or lights. They will often have food, chemical, or drug sensitivity, and they will also have anxiety disorder and or catastrophic thinking. Now, this is clearly a central nervous system dysfunction, and adverse childhood events are strongly associated with the development of chronic and widespread pain. Brain scans have found that these patients are in a constant state of fight or flight. And this is defined as a central nervous system maladaptation. This is not mental illness, but rather the result of nervous system injury or trauma. So the NIH, a multidisciplinary approach to the study of pelvic pain, did an adverse childhood event study in 2018, and they found ACEs elevated in 421 IC patients when compared with controls. The adverse childhood events are associated with complex chronic pain, pain syndromes, and perceived well-being. And the more severe the ACE history, the less likelihood of improvement and worsening of pain symptoms. So what are our therapeutic priorities for this group? Well, we have to turn the amygdala off by telling and training the brain that they are safe. And how do we do that? With mind-body medicine. We need to address anxiety and catastrophizing, which reinforces fight or flight. It's important to embrace positivity because pain that is accompanied by laughter is minimized by the brain, but pain that is accompanied by anxiety and tears is intensified by the brain. And we do have some new research showing that brain nerve stimulation could be very promising, and that is being done by Dr. Jason Kutch at USC. But here's the key. Why have clinical trials for IC failed? We now believe that it's this patient group, the widespread patient group, that's responsible for the majority of clinical trial failures. And we have a new MAP study that found that patients with localized pain respond best to local therapies, whereas widespread pain patients responded best to centrally acting treatments. And they suggest that future clinical trials should differentiate patients based upon the presence of widespread pain. I argued for this a couple of years ago. So what are the advantages of the pain system? Well, it's ideal for use in clinic. It's really simple and easy to explain. It provides an intuitive treatment plan customized for each patient. It helps the patients understand the value of a multimodal approach and validates the use of specific therapies, such as the importance of topical estrogen for estrogen atrophy or antidepressants to calm the central nervous system. And it puts self-care and mind-body medicine into context without offending patients by suggesting that their symptoms are all in their head. But now we go to the big proposal. In 2022, Dr. Curtis Nickel proposed 9 phenotypes for IC. He was passing on the wisdom that he's earned from thousands of patient contacts. And he wrote, I have been asked by urologists many times over decades how to treat a specific patient with IC and found that I gave a different answer based on each patient's clinical picture. A stepwise monotherapy approach is doomed for failure in the majority of patients suffering from IC BPS. In other words, a one-treatment-fits-all approach is ineffective. So he proposes 9 distinct patient groups. His first is inflammatory. This subtype includes patients who have visible inflammation on their bladder and or Hunner's lesions. And he suggests that they should be cauterized multiple times if necessary. He then switches to steroid injections into the lesion. For earlier, milder reoccurrences, he suggests the use of classic rescue installations with chondroitin, heparin, or sodium hyaluronate. But if a patient doesn't respond to those treatments, he suggests oral cyclosporin. His second group is infection-mediated, and he's the only one who's proposed this. He argues that there are patients who have a history of recurring UTIs who may be experiencing a bladder hypersensitivity syndrome secondary to the infection. He suggests applying antibiotics directly to the bladder in bladder installations. He enthusiastically promotes new UTI vaccines like MV140, and he believes in the value of next-generation DNA urine testing in finding rare or more challenging infections. His third group is neurogenic hypersensitivity. This is widespread pain and chronic overlapping pain conditions. For this group, he suggests the use of low-dose antidepressants, bladder installations that support the gag layer, and the use of lidocaine in installations to calm nerves. Our fourth group is multiple allergies. These are patients who have respiratory, environmental, or dietary allergies. This is easily identifiable during a cystoscopy by gently poking the bladder with a cystoscope to look for a mucosal wheal. He suggests a strict diet, antihistamine use, and or cimetidine, as well as the use of rescue installations. His fifth group is pelvic floor pain. He says look for pelvic floor dysfunction, tension, or trigger points. He said focus on therapies that target muscle health like localized heat, stretching, relaxation, physical therapy, skeletal muscle relaxants. He suggests nerve blocks for localized pain and Botox therapy, though he didn't use Botox for this purpose. His sixth group is primary storage symptom syndrome. These patients run to the restroom due to pain on bladder fill. He recommends antimuscarinics once the pain has been controlled, perhaps mirabegron, bladder training to increase capacity, Botox is the last resort, but he does not believe neuromodulation significantly reduces this type of pain. His seventh group is urethral pain syndrome. Again, this is new. He's the only one that's talking about this, with pain in the urethra that is sometimes their only symptom. He says pain can be constant, episodic, or associated with urination. Dr. Nickel believes that these are some of the most difficult patients to treat, and he suggests using topical lidocaine to numb the urethra, vaginal estrogen, local or oral amitriptyline, diazepam, or a periurethral block. His eighth group is sexual pain. He says pain with intimacy must be addressed in patients who are sexually active. Location of the pain must be assessed. Is it coming from the vagina, vulva, pelvic floor, or bladder? He suggests treatment with pelvic floor physical therapy and again some topical lidocaine, topical estrogen to improve skin health and integrity. And his 9th group is IC flares because flares require additional care. They can be triggered by diet, menstruation, stress, other infections, inflammations, and intimacy. They can last from hours to days to months. He suggests diet modification, hormone therapy, stopping irritating vitamins and supplements like cranberry or vitamin C, increasing water intake, stress reduction, heat or cold, short-term antihistamines, etc. And interestingly, he offered a Friday clinic for rescue installations for patients before the weekend. So what are the advantages to his proposal? Well, it takes a deeper dive into potential causes of pelvic pain, particularly urethral and sexual pain. He reminds us that flares require treatment, and his recipes for treatment are thorough and customized for each phenotype. Now let's look and see what the American Urology Association did. In 2022, in their latest update, they also now recognize just 3 groups, but they've combined some of the varied groups into smaller groups. So for example, bladder-centric, the presence of Hunner's lesions, a small bladder capacity, and or pain that improves with local anesthetics. They recognize the pelvic floor group with tight, sensitive pelvic floor muscles, and they clearly recognize the widespread pain group. So what is their treatment approach? Well, they say no single treatment works for the majority of patients. Treatment should be tailored to the specific symptoms, aka phenotype of each patient. And if a patient is not responding to multiple treatments, a diagnosis of IC should be reconsidered. AUA only has 2 treatment recommendations. Hunner's lesion should be identified and treated promptly with the correct lesion-specific therapies, and that patients with pelvic floor tension should be immediately referred to physical therapy. All other treatments are considered options. Now, the current Canadian guidelines were published in 2016, and they rely on the U-point input system proposed by Nickel and Shoskes. But these are currently under revision according to the CUA website, and we don't know to what extent they're going to adapt, change, or incorporate more phenotyping. So let's now look at the clinical application of phenotyping by revisiting our case studies. We've got the 74-year-old female, severe pelvic pain, frequency urgency for 20 years. Cystoscopy finds Hunner's lesions. Lesion therapy hasn't worked. Elmeron for 20 years, antidepressants, etc. What is her phenotype? Well, obviously she fits in the Hunner's lesion phenotype. But she also has genitourinary syndrome of menopause due to her age. She also has pelvic floor dysfunction because of the constant pain she's had from the lesions. And interestingly, she shared with me that she had just been diagnosed with an active Epstein-Barr infection again. So it's the active viral infection that in all likelihood has been there for years that is probably triggering her lesion growth. So she is currently using antivirals, topical estrogen, physical therapy, and pain care as needed. Let's go to our second one, a 38-year-old male. The clue right here is in the first 2 bullets. He was a paratrooper. He has pain exacerbated by sitting. What is his phenotype? He has severe pelvic floor and a tailbone injury resulting from injuries while on active duty. He jumped out of a lot of planes, landed hard on the ground, often on his tailbone. He does have moderate PNE, and now his treatment has to focus on pelvic floor rehabilitation combined with nerve calming treatments. Remember, he was not food sensitive, and on cysto, his bladder is healthy. Bladder therapies make no sense for him. We have to focus on the underlying problem with the muscle injury and nerve injury. Now let's look at the 30-year-old female. Her frequency urgency began in her teens. She has persistent pelvic pain. She has early onset endo with multiple surgeries. Obviously, her phenotype is related to her endo. And we have a brand new study of 533 IC patients that found that 20% of women actually do have a history of endometriosis. They are more likely to have a larger bladder capacity, report chronic pelvic pain, chronic fatigue, migraines, and pelvic floor dysfunction, and that this is associated with a non-bladder-centric phenotype, aka systemic pain disorder. Thus, treatment should be focused on systemic therapies. Now let's look at the 21-year-old male. His symptoms started suddenly at 18. He has severe pain, normal prostate, dropped out of college, bedbound, very diet sensitive. He has severe bladder inflammation on cystoscopy, and he shared that he had been using ketamine recreationally and even had noted bleeding after using ketamine. So he has a bladder wall-driven chemical injury. His treatment should focus on addressing the addiction, managing symptoms while the bladder heals. Traditional IC therapies may be helpful, though all is not if he continues to use ketamine. Now let's look at the 56-year-old female. Her symptoms began at 54. She has moderate nocturia, and the clue is in the third bullet here. She has pain described at the urethra and vaginal introitus. We know what this is. Hello, estrogen atrophy, genitourinary syndrome of menopause. So her priority treatment is going to be topical estrogen. She may benefit from some over-the-counter supplementation, maybe perhaps with the chondroitin-based supplements to support the bladder wall. Soothing topicals might be helpful for her, like vulva balm, topical lidocaine, coconut oil. Bladder coating therapies, like a rescue installation, might be helpful, but it's always important to remember in this patient group that recurring UTI is certainly possible. Now let's look at the last one, the 13-year-old female. Now you may notice a completely different picture here because, hello, this was me. I had sudden onset frequency urgency in 7th grade. I couldn't sit through class without asking to use the restroom. My cultures were negative, antibiotics were ineffective, the dozens of urethral dilations I had were ineffective, and I was very diet sensitive. Now, the challenge here is symptoms changed. I developed vulvodynia in high school, polycystic ovarian syndrome in college, IBS in my 20s, migraines, anxiety, and eventually severe pelvic pain at 32. And yet, my bladder was always normal on cysto. And bladder therapies and antidepressants have always been completely ineffective. Now, once the new research came out about the role of the pelvic floor, I went and had a pelvic floor assessment at the age of 48. And you know what it found? Very tight pelvic floor muscles, especially on my left side. And that physical therapy actually resolved most of my symptoms. Now, right prior to the onset of my symptoms, I had broke the tip of my tailbone off. Coccyx injuries are very common in this patient population, so please probe for injuries. But why did I develop widespread pain? I am an ACE patient. I was attacked by a kid my age for years. He attacked many people. He was mentally ill. I was afraid to go to school for a decade. My safe place was being at home. When he was a teenager, he raped and murdered my neighbor. My brain clearly recognized that threat. We all knew this could happen, and sadly it did. But sadly, I was in fight or flight for 25 years. And I still have moments when I struggle. So what are the questions for patients with widespread pain? Well, can you remember any physical injuries when you were younger? Because 80% of the children who develop widespread pain have a history of injury. Or were you abused or bullied? Were you a victim of sexual assault? Did you live in the home of an alcoholic? That's very common in my office. 20% of patients appear to have this history. More questions. Do you have sensitive skin? Can you wear wool? I can't. Do you have a wicked sense of smell? Yeah, I found many gas leaks. Do you struggle with anxiety or catastrophic thinking? Hello, yes, I did. These are all signs that the central nervous system has been injured and has become sensitive. But why did I get better? Well, number one, I stopped blaming myself. It was never my fault. Remember, it's not what's wrong with you, it's what happened to you that's important. I took a fabulous anxiety management class when I was 35 that stopped the chronic panic attacks and fear that I had lived with for years. Lower adrenaline levels ease my symptoms, and positivity helps too. But because my brain will always remember the trauma, I use techniques that will calm my central nervous system and turn off my amygdala, often daily. And of course, therapy, counseling, and support can be beneficial for those of us with severe trauma, but never suggest that this is all in their head. This is a natural and normal response to severe trauma. Now, what other phenotypes might be included? Lupus and Sjogren's, that's a very small but distinct group. I think we need to learn a lot more about that. I think we also need to learn a lot more about hormone dysfunction, because there's always been a small group of women who flare either when their estrogen levels are very low or when their estrogen levels are very high, but consistently when they get their hormones normalized, their symptoms improve. And we also need a clear understanding of the role of bacteria, fungus, and virus, aka urinary biome abnormalities. And this is where it gets interesting. Is there a remote chance that there's a smoking gun bacteria similar to Helicobacter pylori in stomach ulcers? Well, several past urinary biome IC studies have found less diversity of normal bacteria and an abundance of lactobacillus in the IC patient population. And Dr. Ann Lenore Ackerman at UCLA has made some very interesting breakthroughs recently. So she first replicated the original studies with a group of patients and found that yes, IC patients showed less diversity, more lactobacillus. But then she looked at their data based upon their age. She was the first to do that, and she found that patients under the age of 45 with pain on bladder fill were dominant in lactobacillus. Patients over the age of 60, on the other hand, had far more diversity, including E. coli, Gardnerella, etc., etc. But then she did something no one had ever done. She looked at the biome data based upon phenotype. And this is stunning because patients with pelvic floor dysfunction had a completely normal biome. Patients with pain outside the bladder were often dominant in E. coli and other bacteria, but patients with pain on bladder fill were dominant in a very specific lactobacillus called Lactobacillus inners. So Lactobacillus inners is a recently discovered lactobacillus that was found after someone put blood in a growth medium. It has been associated with other urinary disorders such as overactive bladder. It is a pathogenic gram-negative lactobacillus found in patients struggling with dysbiosis and cancer, and it actually makes a toxin that breaks down epithelial barriers. It does not behave like a normal lactobacillus to kill fungi or E. coli growth. And it's important to note that increased fungal levels have already been found in IC patients, and that bladder pain increases as candida increases. Inners is associated with a poor long-term health in patients with bacterial vaginosis. It is related to higher levels of inflammatory markers such as interleukins. It is an opportunistic lactobacillus that appears to dominate the biome after antibiotic use. And we must remember that most IC patients have been provided extensive antibiotic use prior to their diagnosis. So, is Lactobacillus inners the smoking gun? Not for everybody, but it could be for some of us. Dr. Ackerman has been a lecturer at the American Urology Association for the last 2 years in their course on IC. This year, she ended her presentation with a warning about overprescribing antibiotics. She said, there are systemic effects for antibiotics which might include the enrichment of species like Lactobacillus inners and the overexpansion of fungal species like Candida. These may have long-term, very long-term, bigger consequences that we must keep in the back of our heads. So, I ask you, is IC a bladder disease? Well, only patients with infection or inflammation appear to have a disease process. We know that there are distinct patient groups and phenotypes. We know that most patients with IC have a neuromuscular influences and that 85% have pelvic floor dysfunction. But Urobiome studies really must be expanded to help us understand the role of lactobacillus in Earth. We are long past the days of treating IC with pentosan and antidepressants and giving them the diet and sending them on their way for 6 months. We know a one treatment fits all approach does not work. Phenotyping will help you identify a more effective approach to treatment. So thank you so much. Thank you for listening, and I truly wish you well.